Hi guys, my name is Kayla Stewart and this is my doctoral project, The Benefits of Educational Tools with Patients with Gestational Diabetes. My committee consisted of Dr. Snell, who's my chair, and then also Dr. Finnick and Victoria Shirley, and then obviously our instructor, Dr. Don Maz. Background and significance. As the United States continues to have a large population of obesity and unhealthy lifestyles due to time and convenience, there's been an increasing number of gestational diabetic patients who are unable to make changes to have well-managed glucose levels throughout their third trimester. Gestational diabetes has many risks to pregnant patients and the fetus. When pregnant with gestational diabetes, the mothers are at risk for uncontrolled or elevated blood pressure, preeclampsia. The fetus can be born with hypo or hyperglycemia. They can be delivered early, respiratory distress, and even have a higher risk of developing type 2 diabetes later in life. Data shows that an educational tool providing simple knowledge and about gestational diabetes, including the importance of managing blood sugars, risk of fetal and maternal health, lifestyle changes, alternative management options, and long-term effects of gestational diabetes is effective. The purpose of this scholarly project is to improve the educational process by providing an educational tool for gestational diabetes to increase their knowledge of the importance of well-controlled diabetes. In the descriptive study, the data that was collected by observing the natural occurrence of lifestyle changes the patient made in their environment to protect them and their baby. The secondary aim for this project include the following: adequate resources for our community, improve the quality of life during pregnancy, decrease pregnancy risk, and improve the implementation lifestyle changes for gestational diabetic patients. After reviewing endless amounts of literature on gestational diabetes, several topics were agreed upon, but several were disagreed upon. When reviewing the literature, three main themes that were included were gestational diabetes risk, gestational diabetes education, and gestational diabetes complication, prevention, and intervention. When reviewing the risk, there are more topics in common than just educational, prevention, and interventions. While reviewing the literature found for this project, hard critiquing was used to ensure we were using the best educational tool. With our expertise, we analyzed the material strengths, weaknesses, gaps, and limitations. By reviewing these categories, we were able to identify whether these are reliable resources to use for this project. The strengths in literature critiquing included several contrasts between the articles, different styles of education, processes, size of control, different types of trials, and different interventions. Some had educational material for different cultures, intervention groups, and new educational self-care plans. Some had medical teams for self-management education with a lot of varieties and options. And some even had technology like continuous glucose monitoring. The weakness is obviously some of these were in other countries, other parts of the country. While being in a rural part of the Midwest, we do have limited resources. Some had like clinics in endocrinology, which you're dealing with patients with type 1 and type 2 diabetes, which doesn't go hand in hand with our study. Also, technology can help manage and provide education, but obviously we lack resources here. The gap was combining the studies that were analyzed. There are different types of needs, and it's stated in the articles that a gap is present due to the need for more awareness and interventions. There are limited changes due to the need for more knowledge and direction. The articles stated that the education presentation needed to be critiqued. One of the articles, Gestational Diabetes Self-Care Educational Needs, did lack the awareness and intervention, and it won't improve the overall health of mom and baby, which in return will not provide any beneficial feedback for the project. Now, the limitations, obviously other countries are larger or smaller, different parts of the U.S., obviously, as stated before, they might have more resources or a larger population, and obviously lack of finances or resources. Here is the educational tool that we agreed upon, which is the CDC educational tool for gestational diabetes in both English and Spanish. The educational tool, the theoretical framework, the Lewin's force field analysis. This is a change model in which balance can be achieved after implementation. It allows for someone to be able to break old habits and develop new behaviors. And this is a 3-step approach, which is unfreezing, which is removing the old process or habits, providing the change and learning, and then refreezing once it has become habit. From a management standpoint of nursing, healthcare workers, especially nurses, do not like change. Many nurses become familiar and comfortable with old habits, which is detrimental when management changes a method they feel is currently effective and efficient. So with this, it allows for change to be implemented. Methodology. When acknowledging which method would be best implemented in the quality improvement project, it was identified that a quantitative retrospective study would be best. This study identifies the gestational age at which the participant had a pharmacological therapy implementation to control blood sugar levels. This correlates with a quantitative research method that compares the gestational age prior to the use of the CDC educational tool versus the gestational age after the implementation of the educational tool. The design. The most appropriate design for the beginning of the study was based off of retrospective data from current educational material. Due to the time frame in which the survey was conducted, there needed to be more time to conduct 6 months of pre-educational tool and 6 months of post-educational tool. Being in a rural community, there is limited numbers of gestational diabetic patients, so that would allow for a comparison of more data to be determined if this was the best educational tool to be used to improve gestational diabetic patient outcomes. Using the retrospective data allowed us to use existing data completed before the study, even when it is being planned. The setting obviously was in a women's health clinic, and it was anticipated that 102 EMR or gestational diabetic patients were going to be able to be reviewed during our study. The setting was a women's health clinic, obstetric clinic that had obviously pregnant female patients. It was set in the Midwest in a rural community. For patients to meet the criteria for this project, the inclusion criteria, obviously the patient had to be pregnant, had to be diagnosed with gestational diabetes between 24 and 28 weeks, had to be newly diagnosed for the first time, and had a failed 1-hour glucose, 3-hour glucose, or blood sugar log. The exclusion criteria was a previous positive gestational diabetic diagnosis with previous education over it, diagnosis of type 1 or type 2 diabetes, and previously on medication to control blood sugar levels. Data analysis. The data that was collected is the gestational age in which pharmacological therapy was implemented, a pre-educational versus a post-educational tool. The gestational age numeric would be considered as an interval data type in the doctoral project. According to William Albert in the Measuring of User Experience, interval data is the data that is compared in which each value has a meaning. The gestational age is considered the dependent variable, and the independent variable will be considered the educational material provided by the CDC. The level of measurement was scaled. Scaled measurements allow for a measurement to be compared between two variables. The reasoning is to compare the gestational age before and after the CDC implementation by the educational material provided. The purpose is to delay the intervention of medication to control blood sugar levels in patients with gestational diabetes. The purpose of the study was to determine whether the CDC gestational diabetic educational tool was beneficial by preventing or delaying pharmacological therapy through appropriate diet and exercise changes. Initially, this study was to be a qualitative and a quantitative. By identifying the gestational week, if any, the patient was started on pharmacological therapy. This was the quantitative portion of the project. On the other hand, the qualitative portion was to be a pre and post test to assess the patient's knowledge of before and after education was provided, but this part was removed. Based on the statistics, more than 100 patients with gestational diabetes needed to be enrolled or qualified. Still, after the project was completed, it was found that only a quarter of the required sample size was obtained over 6 months. The study was conducted. After identifying these outcomes, it was agreed that this project would be a descriptive study. Variability: the sample size, which was significantly smaller than initially planned, has affected the study's outcome. There is a significant improvement in the patient outcomes, but the independent sample t-test cannot be performed due to the lack of data collection in the last 6 months post-intervention. This changed the testing from a quantitative study to a descriptive study. If the study was conducted in a larger hospital ministry in a large area outside of a rural part of the United States or over a longer period of time, the outcomes could have changed. The effective time in the study, the data were analyzed as the time series over a year and divided into 2 parts. This is a longitudinal design in which a patient tests positive for gestational diabetes, the series of encounters which the patient will be monitored for uncontrolled glucose levels. The 2-part component span was between January 1st and December 31st of 2025. The first half involved a retrospective collection of data from patients previously seen before the implementation, and then the last 6 was the implementation of the CDC interventional educational tool. The setting and structures of the intervention. The study was conducted in a rural women's health clinic affiliated with a hospital located in the Midwest region of the United States. The hospital estimated between 800 and 1,000 patient encounters per month for OB patients, and the 2 OB-GYNs employed by the hospital estimated about 50 deliveries in a month, which there is a significant increase in gestational diabetes patients between 6 and 8.3%, but this is different in a rural community. It was estimated that 102 sample size had to be present for an independent sample t-test to be conducted. Pre-intervention, the sample size was 16. Post-intervention, it was 23. So in total, the sample size was only 39. So when looking at the figures, the first one shows pre-intervention management, and it shows the percentage between diet control, pharmacological therapy, and the outliers in this study. And then below, it shows the breakdown of the numbers of patients and then the percentage. And then here's the contrast with the post-intervention management in figure 4 and the pie chart. And then here's the breakdown of the intervention or post-intervention data. And then here we go into a pre and post comparison of what pharmacological therapy was implemented, whether it was insulin, glyburide, or the outliers. And then here it shows in table 5 and 6, the post-intervention and the pre-intervention of when the pharmacological therapy had been initiated. So when going over the project implementation timeline diagram, we first start with the evaluation assessment phase, in which is discussing with providers, clinical management, administration about the potential project. Then the planning phase, which we go into specific details of plan for implementation and what the project would involve. And then preparing for the IRB interview. Then the obviously interview process with the IRB, which was a process of the first hospital, then the buyout hospital, and then also Maryville University. And then planning with the staff meetings about the process and the protocols, and then obviously getting the approval from the IRB chair, clinic management to carry through and implement, and then obviously the implementation process and collecting the data. The process measures and outcomes. With the data that was collected, it was reviewed with the mathematician and the IRB chair, and it was determined that the sample size was smaller, so obviously it had to be a descriptive study. The data that was collected did show a significant decrease in patients that had to start pharmacological therapy, which, with the prediction, it did show delay in prevention. With the contextual elements that interacted with the interventions, obviously the hospital got bought out, which delayed having 3 IRB processes. There was a slight process of a incorrect submission of one of the IRB reviews, and there was corrections made to the project itself to be a quantitative and not a qualitative as well. And then there was some slight delays with the EHR system running reports at the end, and it had to be refigured with the IT department. And then also staff reminders, trying to remind them about the project, and also when new staff members were started, a lot of times it was forgotten to educate them. Observed association between outcomes, interventions, and relevant contextual elements. Initially, the data that was to be analyzed using an independent sample t-test or a Mann-Whitney test. After the sample data was collected and entered into a spreadsheet for scaling, it was determined that that the required sample size would not be obtained. After discussion with the IRB chair and the instructor and meeting with the mathematician, during the meeting we did believe that a descriptive study would be more beneficial to provide evidence, and the evidence that was collected did show that there was positive outcomes for the educational tool during the study. If it was done on a larger scale, or longer period of time, you would be able to provide an independent sample t-test. In the retrospective data collected over the previous 6 months of the gestational education intervention, it was identified that only 3 patients were able to achieve diet-controlled glucose management. However, in the post-implementation group, 13 patients were able to achieve diet control management. This leads to credibility to a positive impact on the education intervention. Compared to the type of pharmacological implementation for these patients, data were collected on which medications were prescribed, which was shown before in this presentation. In comparison with the pre-intervention data, it was identified that 23 patients, only 17 were prescribed pharmacological therapy for glucose control at the end of pregnancy. It was identified that it could be provider preference on treatment options for gestational diabetes, both pre and post-intervention. Unintended consequences. There were some things that did change the outcomes, which did include, obviously, sample size being smaller did affect the outcome of the study, and not being able to run the independent sample t-test. And then staffing and communication. There was new staff that were hired on, and education wasn't provided, so there was some patients that were considered outliers. Also, some of the outliers were transfer patients that were initial C-sections, repeat C-sections, or VBAC patients, or patients that had type 1, type 2 diabetes or on pharmacological therapies already. With the transfer patients, they weren't provided the educational tools initially, so it could have prevented them from being on pharmacological therapy started by a previous provider. And even though we provided them the education, in the end, they did decrease the odds or the risk of complications in pregnancy. Limitations. Obviously, sample size was a limitation. Based off of 102 gestational diabetic patients that needed to be completed, we only received like a quarter of that. But also with the location being in the Midwest and a rural community, that did affect that. 6-8% of the populations are typically diagnosed with gestational diabetes and can increase based off the location. But being in a rural community, obviously that's a lot smaller. When examining the broader gestational diabetes patient population in the U.S., there's a lack of compliance and consistency across clinics. In the rural Midwest, where this study was conducted, there was no uniformity in education or processes for newly diagnosed gestational diabetic patients. When looking at the clinic, the process for providing this education is very inconsistent due to staffing, provider preference, hospital preference, and outdated processes. Many staff provided education based off the provider preference, but this material often became outdated, and that can affect patient outcomes. The stakeholders were the group affected by the intervention implementation in this process, which the stakeholders were the high-risk specialty patients being seen in the clinic. Several patients were appreciative to be appropriately educated about the changes that could affect the outcomes of both them and their baby. Also, the results of the project, the clinic and hospital staff noticed a decrease in risk of complications from uncontrolled blood sugar levels, which include preeclampsia, preterm labor, gestational hypertension, etc. These provided a clinic staff, leadership, providers, administration, and even risk teams that were impressed by the outcomes and decreased the risk of maternal patients. These goals are continually assessed by hospital management in accordance with policies and guidelines. These are natural objectives with the Joint Commission, the International World Health Organization, that helps improve maternal rates. The workflow efficiencies were excellent if there were no new staff members or floats from the other department. As stated previously, if a book that was providing updates to new staff members or floats in the break room or even in staff meetings, this would allow for staff members to be updated on changes. The cultural shift, there was one provider that did not want to be involved or did not do much in her MA, which did affect the study some. Sustainability, very positive, is with little to no cost, except for paper, but if we used a attachment or a handout in the patient chart during their discharge for every visit, this would prevent that cost from occurring. And this had positive outcomes. So with a larger scale and more studies, I think it would be sustainable and be very beneficial for patients. In the nursing profession, we have standard and guidelines to adhere to the structure of the healthcare system, promote patient safety, and to do no harm. So with this project, going through the IRB process and everything else, it is in the nurses and providers' best interest to follow forward with doing this to provide patients with the most up-to-date educational material, which provides better patient outcomes. And with improving patient safety and outcomes, this follows Joint Commission guidelines, which most hospitals do have to complete these every couple years. The IRB evaluation is still to be conducted, but I think with the benefit of this, I think it would be very positive and even to be looked at a larger scale within the ministry hospital. With the legal diversity, equity, inclusion, and advocacy, there was no legal issues with the project at all. As stated before, this project will provide a decrease in the use of pharmacological therapy, but also improve both patient and baby's health. This will drastically impact the patient population, especially if this implementation is rolled out in the ministry level. Also, this will allow for better communication, teamwork, and workflow to effectively educate all gestational diabetic patients as well. The results did show 57% were diet-controlled gestational diabetics, and only 17 were started on pharmacological therapy. 26 of the population were considered outliers. Amongst patients treated with pharmacological therapy, only 2 of the 23 started on insulin, and 2 were started on glyburide. Based on these numbers, there was a significant difference between pre- and post-intervention periods. The proportion of diet-controlled gestational diabetic patients increased from 19 to 57%, which is a 38% difference. This is a dramatic improvement and will, in turn, decrease the risk of both the mother and fetus complications during pregnancy, postpartum, and in the long term. As discussed previously, this is a small scale that was used due to rural Midwest, so at a larger scale in a larger population, longer period of time or ministry, this would show better results of how this can be beneficial. Significant success, huge improvement in patient safety and outcomes over a short period of time. When using up-to-date educational material, it does improve lifestyle changes, which in return does help with their health and prevent pregnancy complications. These do show the potential of policy and procedural changes to continue to improve high-risk population, which will allow for better communication, teamwork, workflow, and effectively educate all gestational diabetic patients. This program and this project has drastically helped me not only personally but professionally to be able to better communicate, build a relationship, and better serve my patients for long-term management. And I am so thankful, and I can't thank you guys enough. So thank you for listening to my project. This is my references. And if you have any questions, you can reach out at this email, and I hope you guys have a wonderful day. Thank you.